Okay, good morning, everyone here in Brazil, and good afternoon, everyone in Barcelona. Today, this morning, we have a pleasure to have a good friend, Dr. Albert Carrion, here, and I just will show you a few slides just to introduce our friend, because this history hasn't begun today. It started first with this doctor here, Dr. Antonio Alcaraz. He's a friend of us. He came a lot of times here in Brazil to share his experience. This is our chair, Professor Ronaldo Damião, and of course here is Dr. Gaston, if I'm not wrong. I think it's Dr. Gaston. He's a friend, one of the best surgeons I have ever seen, most skilled that I have ever seen. This is part of our team in the National Academy of Medicine here in Rio de Janeiro. After this meeting, I made a small observer fellowship, a few months. I spent in Hospital Clinic in Barcelona. It's a big hospital from University of Barcelona, very nice place. And then I spent these months. If you can see here, I'm here. This was my first time with robotics and you can see here Dr. Albert as a robotic assistant, and Dr. Antonio Alcaraz was doing this surgery. It was 2012, and it was a private surgery, and it was a very nice surgery with Dr. Antonio Alcaraz. This is the team, part of the team. Albert is not there, of the Hospital Clinic. Albert was a resident of the fifth year. I had just finished my residence 1 year before, and people were very friendly, very hospitality. And we can see here Dr. Maria Ribal, another impressionant surgery, talent, other residents here, and I had a good time there during this period. Just to show you, this is Barcelona, the architecture, and the food, Mediterranean food. I remember, always remember Mediterranean food is very, very nice, and I really had a great time there. Okay, just to show this slide, introduce my friend. Dr. Albert, as I told you, was a resident in 2012 when I went there, and now he's a leader. He moved to Hospital Vall Hebron. Now he's PhD, and he works most with bladder cancer. He's a member of the EAU panel of bladder cancer. And well, I'm sure we will share our experience and listen him. And Albert, again, thank you very much for your acceptance to our invitation. We are delighted to have you here. And please, the stage is yours. Welcome again.
Thank you, Paulo Roberto, for your words. And again, I want to thank you for inviting me to share our experience in the robotic management of bladder cancer. I want to say as well that it was a privilege of having you in Barcelona some years ago. It's been like 10 years ago that we met there. I was making my residence there in Hospital Clinic, so we could share some experience there. And after that, I stayed in Hospital Clinic for 2 years, but I was involved in the management of the stone disease. but then I have the possibility to change to another hospital here in Barcelona, because they offered me to be involved in the urothelial carcinoma group. So I decided to move to the other hospital. Since my beginnings in the urological community, I was really interested in the urothelial carcinoma management. So I decided to change, and now I'm working since 5 years in Hospital Hebron of Barcelona. Hospital, let me share my screen. Can you see my screen now? Yes?
Yes.
Okay, nice. So as you said, I'm a member of the European Urology Guidelines panel. I'm involved since this year in the muscle invasive and metastatic panel group. And my field of interest is mainly the bladder cancer management. So this is my hospital. This is Hospital Vall Hebron in Barcelona. It's a tertiary hospital here in Spain. It's the biggest one in Catalonia and the second one in Spain. We currently have available 3 robots at our hospital, at the department, 3 Da Vinci robots. So we are the only hospital in Spain that have currently 3 robots available. And that's the reason why we are now performing more than 70% of major surgeries using this platform. We are now performing all the partial nephrectomies with the Da Vinci robot, all the radical cystectomies, radical prostatectomies, and now we are starting as well, not me, but my colleagues from the same department are starting with organ prolapse repair using the Da Vinci robot, and also the ureteral reconstruction using this platform. So as you may know, bladder cancer is the 7th most frequent cancer worldwide, and it's the 5th in Spain. We have the highest incidence of bladder cancer in Europe, in Spain. It may be because of the age of the elderly population that we have. The expectancy in our population is really high, and maybe because we have a high population that are currently smokers or former smokers. So that's the reason why we have the highest incidence of bladder cancer in all Europe. And we know that at this time, 25% of tumors are muscle invasive at the time of the diagnosis. And we know that radical cystectomy is still the gold standard treatment for this disease. So we have seen in the last decades that the 5-year overall survival of this tumor, of the muscle invasive stage, is 50%. And it's hard to say that the prognosis has not changed in the last decades, although the new developments in therapies, in minimal invasive surgery, and in new oncological therapies, the prognosis has not changed. I would say that the only thing that has changed the paradigm of this disease is only the neoadjuvant chemotherapy that has improved the survival in 5% of patients at 5 years of follow-up. And now we are currently using neoadjuvant chemotherapy in almost all our patients. So this is the only thing that has changed a little bit the prognosis in a big way of this type of tumor. So what is the gold standard treatment for muscle invasive or high risk non-muscle invasive disease is the open radical cystectomy. Is the gold standard approach, but this approach has changed a little bit in the last years. With the increase of minimal invasive procedure, we have seen changes in the last years in the European Urology Guidelines recommendations. And now we can see in the recommendations that both procedures, the open assisted radical cystectomy and the open approach, are both equally safe and maybe equal in terms of oncological outcomes. Some years ago, we didn't have enough evidence to say that robot-assisted radical cystectomy has equivalent in terms of oncological outcomes with compared to open approach. But now if we look at recommendations of the EU guidelines, we can see that the robot-assisted radical cystectomy could give in equal oncological outcomes, and it depends mainly on select experienced centers and experienced surgeons, but not in selecting a specific technique. I mean, if you have enough skills performing robotic surgery, if you have a department where you make more than maybe 30 cases per year, then you could have good oncological outcomes with the robotic approach. And what were the concerns about using this approach at the beginning of the series when we start doing robot-assisted radical cystectomies? The concerns were the risk of having a positive margin rate, a high positive margin rate. The concerns were about having inferior oncological outcomes compared to the open approach, maybe because of the highest risk of having local or atypical recurrence, such as port site metastasis or carcinomatosis, peritoneal carcinomatosis, that could be related to the use of pneumoperitoneum, that, as you may know, this pneumoperitoneum environment could increase the risk of tumor seeding. There were always also concerns about the cost effectiveness of the robotic platform, the longer operative times, and the lack of tactile feedback that could increase that risk of positive margin rate. And which could be the potential benefit of the robot? That those benefits that are the same that in minimal invasive techniques, that are the decrease in blood loss, the decrease in pain, the decrease in maybe in postoperative complications, and in the length of hospital stay. And this is the most important paper that has been published regarding the robot-assisted management of bladder cancer, that was published in Lancet in 2018, and is a non-randomized, is a randomized control trial that it has a really well designed. So it was published some years ago, and it compared more than 100 robot-assisted radical cystectomies with more than 100 open radical cystectomies. It was, I repeat, a randomized study, and it was a non-inferior study that showed that the robotic approach was not inferior to the open approach in terms of survival, complications, and quality of life, with 2 years of follow-up. That this has been confirmed at 3 years of follow-up. And this is another paper that was published in European Urology, that it is also a randomized trial comparing both approaches, and it showed similar survival and perioperative outcomes between both groups, in the robotic group and the open radical cystectomy group. But it is important to say that in the robotic group, they found more local recurrence and peritoneal implants compared to the open approach. So this could be because of the use of pneumoperitoneum during the surgery. But if we look not just the conclusion, if we look the paper, if we read the paper, we can see that this high incidence of local recurrence did not have an impact on the survival of the patients. I mean, it seems that the way of spreading of the tumor, the way it spreads the tumor, it's different from the robotic approach than the open approach, but the survival, it's really similar. So it has a big limitation, this study, that mainly all the cases that include robot-assisted radical cystectomy were with extracorporeal urinary diversion. That this is not the real scenario at this time, because now we are seeing that most patients are treated with intracorporeal urinary diversion. And if we make just a break, I want to show you the results of a study that we published in Hospital Clinic in 2016, where we investigate the role of the laparoscopic in the management of upper urinary tract tumors. And we found that entering the urinary tract during a laparoscopic radical nephroterectomy was related to local recurrence. And we conclude that the risk of local recurrence could be increased in that patients that you incidentally enter the urinary tract during the dissection of the kidney, then you could increase the risk of tumor seeding. So it's important to say that the 20 cases where the urinary tract were opened were at the beginning of the series in 2007, where we don't have enough skills in laparoscopic surgery. I would say that this is not the same risk regarding the management of bladder cancer, but because, as you know, it's not the same to operate a bladder using the robotic approach, that the bladder is empty with a catheter inside, and it's really difficulty to enter into the bladder. I mean, we have more than 120 cases of robot-assisted radical cystectomies, and we haven't entered in the urinary tract even in one case. But it's really, it's more frequent to enter the urinary tract during the dissection of upper urinary tract tumors, when you have a big hydronephrosis and when you manipulate a tumor in a pneumoperitoneum environment. So be aware of that risk, not manipulate too much the tumor, not entering the urinary tract during the robot-assisted approach. And what we can find, this is a meta-analysis that was published recently in British Journal of Urology. It includes 5 randomized controlled trials comparing more than 500 participants, and it compares both open and robot-assisted approach, and it found similar oncological outcomes in terms of recurrence, complications, quality of life. But it's important to say that in the robotic arm, they found less blood transfusion rate and less length of hospital stay. And what about the extracorporeal urinary diversion compared to the intracorporeal? We know that papers that compare the open approach with the robot-assisted approach usually include extracorporeal urinary diversion. But now we are seeing that we are using more and more the intracorporeal approach. So we need more evidence, we need more research, including intracorporeal urinary diversions. And what about the potential benefits of using the intracorporeal urinary diversion? Would be the decrease in blood loss, maybe, the less pain, the smaller incision, the faster return to a bowel function, and maybe a fewer anastomotic stricture rate. And this is a paper that was published by Tan and colleagues that compared extracorporeal urinary diversion with intracorporeal, and they found a shortened complications in the intracorporeal approach. And they found also a reduced in estimated blood loss in the intracorporeal approach. And we did the same. We made a study that was published 2 years ago in Actas of Urologia, where we investigate the role of the extracorporeal approach compared to the intracorporeal. And we compared 22 cases with the extracorporeal with 21 cases with the intracorporeal. And what we found is that there were no difference in regarding the operative time and postoperative complications, but it's important to say that we found a higher rate of ureterenteric stricture in the extracorporeal approach compared to the intracorporeal. And this could be because the higher dissection of the ureters that you need to do while making an extracorporeal approach. I mean, when you perform the extracorporeal approach, you need to put the bowel outside the body. So you have to dissect too much the ureters below the iliac vessels, because you need to move the ureter towards the bowel and make the anastomosis outside the body. Then you put the urinary diversion inside the body again. So with the intracorporeal approach, we try not to dissect too much the ureters, not below the iliac vessels. So what we try to do is to move the bowel towards the ureter and not the ureter towards the bowel. So we can manage to make a free anastomosis, a free tension anastomosis, and try not to dissect too much the ureters in order to have a less risk of ureterenteric strictures. And this is a paper that is a systematic review that includes 7 papers comparing the extracorporeal with the intracorporeal approach. And it includes also our paper. And the conclusion was that both had comparable short-term and mid-term complication rates, but the intracorporeal group had lower blood loss and lower rate of blood transfusion compared to the extracorporeal. And what about the risk of having a ureterenteric stricture after using the intracorporeal urinary diversion? How can we manage to reduce that risk? We can try not to dissect too much the ureters, as we have already said, but we can also use the indocyanine green. The ICG, as you know, is a non-toxic tracer that helps to assess the vascularization of the ureter. And this is a paper that was published in British Journal of Urology that is a retrospective paper, but compare more than 100 patients that were treated without injecting ICG with 47 patients that were treated injecting ICG. and they found that the ureteroenteric stricture was 10% in the non-ICG group compared to 0% in the ICG group. It's important to say that we need more randomized trials comparing both techniques, but it looks like that there is an enthusiastic future in the use of this type of non-toxic tracer. And now we are using it in all cases that we are performing at our department. And we haven't reported any case of complications regarding the installation of this ICG. We will see in the near future if it really decreases the risk of having a ureteroenteric stricture using the intracorporeal urinary diversion. And what about the learning curve of this procedure? We know that this is a really complex procedure. It's one of the most difficult and the largest procedure that we have in urology. And there have been some parameters that have been proposed to evaluate the learning curve of this technique. There are some parameters that were included in the robot-assisted radical cystectomy learning curve, that are the operative time, the estimated blood loss, the positive margin rate, and the number of lymph nodes. And there are parameters that evaluate the learning curve of the intracorporeal urinary diversion. These are the ureteroenteric stricture, the urinary leakage, and the bowel leakage. Both parameters were included in the Pasadena's consensus, and they conclude that you have to perform at least 30 procedures to complete the learning curve in order to assure good outcomes with this procedure. In my opinion, it may be more than 30. It may be at least 50 cases that you have to perform to have enough skills with the learning curve. But what it says in the literature is that with 30 procedures, you will have enough skills and experience. We also make a study that has been accepted in Actas of Urologia this year to evaluate the impact of the learning curve on our perioperative outcomes using the robot-assisted radical cystectomy with the intracorporeal urinary diversion. And what we do is we compared 3 consecutive groups of patients, all of them treated with intracorporeal diversions. And we compared the first group that had 20 cases with the second one that include 20 cases, and the third one with 21 cases or 21 surgeries. The first group were performed by a senior surgeon that had previous experience in robotic surgery. And the second and the third group were performed by 2 junior surgeons that didn't have experience in robotic surgery, but mentored by the senior one. And what we found is that no difference in perioperative complications, number of lymph nodes, positive margin rate, of length of hospital stay were reported between the 3 groups. But what is important to say is that we found that the operative time was 60 minutes shorter in the third group compared to the first group, and the ureteroenteric stricture rate decreased from 25% in the first group to 9% in the third group. So what we can conclude is that although 2 junior surgeons were included in the second and the third group, if you have a mentor during all the procedure, you could decrease the operating time from 1 hour between the third group and the first group, and you also could decrease the risk of having a ureteroenteric stricture during the learning curve. And this also has been confirmed in papers that has been recently published. This is a paper published in Journal of Urology that evaluate the learning curve and the impact of the learning curve on the development of ureteroenteric stricture using the intracorporeal urinary diversion. And they found that there were a peak incidence of a stricture during the first year of start using this approach. It was 47%, which is really, really high. It's a risk of developing a ureteroenteric stricture is a high risk. But they found that an important decrease of this rate to 14% in the 5th year of using this technique. So during the learning curve, you have to be aware of having that high rate of stricture during the first cases. So maybe with the use of indocyanine green, we could reduce that risk. We will see it in the near future. And now I want to change a little bit the topic. I want to explain some solutions, robotic solutions for robot-assisted radical cystectomy complications. During a lot of years, we have used the open approach to reoperate patients that had received a previous radical cystectomy, but now we start using a robotic approach also for managing these complications. And one of the most important complications after a robot or a radical cystectomy is the ureteroenteric stricture, as we said before. And we know that the incidence of developing a ureteroenteric stricture is between 2 and 19%, depending on how they report this complication. I would say that many departments is underestimated, the numbers that they show. But what we have in the literature is that is between 2% and 90%. And this stricture is because the devascularization of the ureter and the fibrosis that could increase in the surrounding of the ureter that could lead to a stricture that we know that it's the first cause of kidney function impairment during the follow-up after a radical cystectomy. And we know that it's the first cause of reoperation after a radical cystectomy as well. We know very well which are the risk factors of a stricture, like hydronephrosis, urinary infections, or postoperative complications. And we know what, and as you know, the management, we have several options in managing this complication. The easiest option would be to lift a urethral catheter or a nephrostomy tube, but we know that this includes high costs, an impairment in quality of life of the patient, and increased complications, mainly infections and other complications related to the use of a permanent urethral catheter. Another way to treat these patients is the endoscopic treatment, that could be the dilatation, the endoscopic dilation of the stricture, or performing an endoureterectomy. But we know that it has less than 18% of success. And although it's a really conservative management and it has not a high rate of complications, the success is really, really low. So what is the best way to solve these complications? We know that is the ureteroenteric reimplantation of the ureter, but most surgeons are scared about performing the surgery because we know that it's a really complex procedure. To operate a previous open abdomen is really, really difficult. You will find attachments, scars. You will have a high risk of iatrogenic injuries. So not all the departments think about performing this procedure, but we know that the open approach of this procedure is the gold standard, but we have a high risk of perioperative complications. There is a paper published by Pakiam and colleagues that found 48% of complications after an open management, an open reimplantation, and 12 of them were major. So there have also been published some cases of laparoscopic approach, and there have been a handful of small case series showing promising results using the robotic platform. It's important to say that the team that would go for a robotic approach must have enough experience in the robotic management of bladder cancer. I mean performing radical cystectomies, and then he can move to new applications of the robotic approach. And this is a paper that was published in Journal of Urology that investigates the role of robot-assisted reimplantation for the management of ureteroenteric strictures. And they compare 6 open approaches with 16 robotic approaches, finding 90% of success in both groups. And there were no difference in regarding the complication or success rate that was 19%. but it's important to say that it only includes 16 cases of robotic approach. And this is the paper that includes more cases in all the literature, including this type of procedure. And we start performing some cases of robot-assisted robot-assisted reimplantation. So we try to make a multicentric study, but before explaining you this multicentric study, I want to show you this study that investigate the role of instillation of ICG through a nephrostomy tube. They present 10 cases of robot-assisted reimplantation with the use of ICG through the nephrostomy tube in order to identify the ureter easier. So they recommend to use always this maneuver in order to find the ureter. As you can see here in this image, you can see the ICG inside the ureter. So you will have you will have more help in identifying the ureter and try to reimplantate this ureter in the neobladder in the Breaker derivation. And what about the study that we did 1 year ago? It's not been published. It has not been published yet, but it's under review in Journal of Urology. As you see, we only have 16 cases. The large series that has been published regarding the type of regarding this approach include 16 cases. So we try to make a multicentric study, including hospitals in Spain, but also in the United States and in Sweden. And our results showed that we had 63 cases of robot-assisted reimplantations with a median follow-up of 22 months, and 42 of patients had a prior Breaker diversion, 17 had neobladders, and 2 had Indiana approach diversions. And what are our results? We found that 37% of patients had postoperative complications, 32 of them were minor, and 5 of them were major. Only 5% compared to the 12% that they found in the open approach. The median length of hospital stay was 3 days, and the readmission rate was 5%. At the median follow-up of 19 months, we found that 84% of patients were stricture-free. So we have a high rate of success. And the only prognostic factor that was related to the success was the lack of prior radiotherapy. So what I would say that most of the patients would be candidate to undergo this procedure, but be aware of patients that had previous abdominal radiotherapy, but you will find a less rate of success after the reimplantation. And just to finish my presentation, I want to show you this case that we performed 1 year ago, that it is published in Journal of Endourology's case report. This was a robot-assisted complete urinary tract extirpation. This is a patient, a 65-year-old patient with a history of more than 10 TURBs for low-grade non-muscle invasive bladder cancer, who developed a simultaneous panurothelial carcinoma involving all the urinary tract. He has tumor, a multifocal tumor in the bladder, a multifocal tumor involving all the urethra, and a bilateral upper urinary tract tumor as well. So after talking with the patient, we decide to go to an aggressive surgery, and we decide to go for a robot-assisted complete urinary tract extirpation. And we did it. We performed it. The operative time was 370 minutes. The blood loss was 460 milliliters. And we didn't report any intraoperative complication. And we didn't have any, we just have one postoperative complication that was a surgical site infection in the glands that was solved with antibiotic without requiring any intervention. And this is the picture of the incisions. We have to move the patient and to first do one kidney, the other kidney, and then the radical cystectomy. And this is the picture of the en bloc specimen, including both kidneys, the bladder, ureters, and all the urethra. And this is the image of the pathological report. As you can see, we have like a big infection in the kidneys, and there is tumor inside inside the upper urinary tract and in the bladder. And the final pathological report was a multifocal PTA low grade in the bladder, a multifocal PTA low grade, including all the urethra, the prostatic, the vulvar, the membranous, and the penile urethra, and a 4 centimeters PT3 high grade in the right renal pelvis, and a 5 centimeters PT1 high grade in the left renal pelvis. And the lymph node was negative. So now the patient is recurrence free. And we are planning, after waiting maybe 2 years, we will see, but we are planning to make a kidney transplantation in the Breaker, in a previous Breaker derivation, but we will see how is the oncological outcomes of the procedure. So that's all. Thank you for your attention, and I will be really glad to answer if you have any question and discuss and share your experience at your department. Thank you very much.
Hi, Albert. First of all, I would like to thank you so much. So it's a Saturday. You are now in Barcelona in the afternoon, in the summer.
Yeah.
And the summer, here is winter, but there's summer. So thank you for you to your presentation, your brilliant presentation, to talk about your experience to us. You could be now in the Cerveceria Vaso de Oro in Barceloneta, drinking some beer, no, but you are with us. First of all, Albert, I would like just to present to you our servers. In Brazil, we have the private servers and the public servers. And the private servers, the technology comes first here. Our servers is the University of State of Rio de Janeiro, is one of the biggest urology servers in Brazil. We have now all specialties in urology. We have the kidney, we have the pediatric, the transplantation, and of course the oncology group. Nowadays we have, I think it's almost 30 faculties there, and yeah, it's a big service, and 13 residents. Is four residents per year, and we have one resident about kidney transplantation too. Now we have the Da Vinci system, the XI. We have that for 3 years. When we already have a focal one to do HIFU too. We have laser to do whole up. So in the public system, we have all the technologies to give to our patients. And let's talk about your presentation. It was a brilliant one. That last picture that you showed to us about the complete expression was beautiful. Congratulations for that.
Thank you.
So Albert, nowadays we have a pleasure to have the technology. We are about the same age, and if we talk about a robot cystectomy with intracorporeal diversion like 15 years ago, we would say, wow, that's impossible. We wouldn't believe in that. But nowadays we see this is the reality. In your presentation, you talked about the RAZOR trial. The RAZOR trial was made by Dr. Parek in the University of Miami. And I had the opportunity to be there in It was 2016. It was in 16, and I stayed there. And in 16, they were doing most of the cases with the extracorporeal diversion. And in the last year, Professor Carretti, that's here with us, he was there too. And in the last year, he was doing almost all the cases in the intracorporeal diversion. So we're getting the skills and about the new technology to improve that. And you showed in your presentation that we can do that. And I would like to do some questions for you. What about the diversion, Albert? The new bladder is much more difficult to do than the breaker. Which patients you option for the new bladder? Which one you option for the breaker? About the oncologic and about the patient, the status.
Yes, well, as you know, you have to speak with the patient first, and you, in my opinion, you don't have to be scared about using the intracorporeal diversion for a neobladder. I mean, we start doing breaker at first with the intracorporeal, then we move to the neobladder as well. We have like contraindications, clear contraindications for going to a neobladder. I would say, as you know, that if you have tumor in the urethra, you cannot go to a neobladder, or you have a patient that has an impairment of the kidney function. You have to be aware of using this neobladder. So I would go maybe for a breaker, for an ileal conduit. But I would say that age is not a contraindication. I mean, if you have a patient that is 90 years old, you would go for an ileal conduit or a cutaneous ureterostomy. But if you have a patient that is 70 years old and he plays tennis every week, so you could go for a neobladder. I mean, age is not a contraindication anymore. But you have to explain the patient that there is a risk of incontinence, urinary incontinence during the night. So he has to know that there is that risk, that he will have to learn how to empty his bladder. He may need in the future to autocatheterize his bladder. So you have to explain everything. With that, now, what we found when we compared the extracorporeal with the intracorporeal, this is important to say, is that we thought at first that the extracorporeal would have like a decrease in the operating time compared to the intracorporeal. But after using the intracorporeal in several cases of neobladder, we found that the intracorporeal, the operating time decrease with the intracorporeal, because you don't have to open the abdomen, you don't have to remove the bowel and then put it inside again and do the urethral anastomosis with the robot, the Da Vinci robot. That is how we perform that surgery at first. We make the neobladder outside the body, then we put it inside and we do with the robot the urethral anastomosis. Now we are performing all intracorporeal and the operating time is decreased compared to the extracorporeal. The bowel anastomosis is really, really fast. In 15 minutes, you could have the anastomosis released. So I think that we have to be open-minded and not scared about using this approach. Are you using this approach in Brazil, or what about you? What do you think about that?
Yeah, the Professor Carretti, he will say some words. He is our leader in the cystectomy group, and he's doing some cases. I'm not sure, but I think he did
have. Let me show our results. It's a beginning the program. Paulo, coloca aquele slide que eu te passei aqui. We begin our program, robotic cystectomy, on September 19, you make three cases with ureteric cutaneous anasoma derivation. And then I went to Miami, and we have to stop the program because the COVID-19.
Of course.
And we returned a few months ago. We have four ureteric cutaneous derivation, 4 brick, and neobladder, all intracorporeal derivation, no extracorporeal, all intracorporeal, or option to make
Can you see?
all intracorporeal derivation with the mean time 306 minutes in media, and but our case is very advanced.
You see the screen, my screen?
Yes.
Okay.
And we have cases with two more very advanced stage 3, 4, most of them. Passa o próximo para a gente mostrar, Paulo. So PT3 to 4 in 18% of the cases. We have one ureteric stenosis in the ureteric enteric stenosis because this patient complicated. He is a T4, T4 and complicate with the ileum and have a urinary fistula, and then we develop a straight. But we was beginning our program, and we we are in the learning curve, only 9 cases, but we'll try do it to more best we can.
Yeah, we see that in that 9 cases is in the literature is like 10% of urethral stricture. So is a great number. So Albert, about the stricture, I would like to ask you do you use the ICG in all cases? If you have the opportunity, in the practice, this is really help about avoid the stricture to see the vascularization. Albert, sorry, we are with no sound.
Yeah. Okay. Nice. So yes, we are using it in all cases now. It's a non-toxic tracer. We haven't reported any case of adverse effect or secondary effect, something like that. And it really helps to see how is the vascularization of the ureter. I mean, when you instillate the ICG, you could really see if the ureter, the distal ureter, it has enough vascularization. Sometimes we find that there is not enough vascularization, then we cut a little bit higher the ureter. So you can check very, very well how is the vascularization. What we don't know yet is that this maneuver could help in preventing the stricture. We don't know yet. We have seen it in retrospective studies, but we need more evidence. We need randomized controlled trials comparing ICG-yes, non-ICG, to see if it has an impact on the stricture. But what you can see really, really well is the vascularization of the ureter. So now when we see that the ureter is dark and it's not with the green, then we cut the ureter a little bit higher, so we can assure that that part, distal part, has enough vascularization. So I would recommend to do it. It's really easy to do it. I mean, you just you just have to say it to tell it to the anesthesiologist, and he will put it through the vein, and that's enough. In 10 seconds, you will see how is the vascularization. And it's also useful to see the vascularization of the anastomosis, of the bowel anastomosis. I mean, when you instillate the ICG, you can check also the bowel anastomosis if it has good vascularization. So you can be like more confident that everything is okay. So I want to congratulate your initial series, because this is the way I think. The problem of the Da Vinci robot in the public system is that it's not always available. In fact, we have a lot of hospitals here in Spain that has not the Da Vinci robot. So, but I think that it's the way. But I'm also confident about that. If you have a surgeon with a lot of skills in open surgery, you will find good results as well. I mean, I have seen surgeons, all surgeons with a lot of experience in open approaches, that the estimated blood loss is even less than in robotic approach. I mean, it not depends on the technique that you use. It depends on the experience that you have with that technique. Okay, but I would say that at first we thought that the robot approach would be like a miracle, and now when we look the numbers, we can say that you can find a decrease in the length of hospital stay. Maybe you can find a decrease in blood lost. You can find a decrease in pain, maybe, but it's not like a miracle compared to the open approach. So I must say that as well.
I agree with you.
Mm.
I think the same.
Mm-hmm. Mm-hmm.
Albert, thank you very much again. I have some words to say. I want to share my small experience. As Fernando said, Dr. Fabrizio Carreretti is our leader in the cystectomy robotic program. We have been doing cystectomies for decades there, and not like you, because as you said in the beginning of your presentation, the incidence of bladder cancer is very high. I remember when I was in hospital clinic, you sometimes were doing 2 cystectomies or 3 in the same day, open and laparoscopic, I remember. In my small experience, I could help Dr. Fabrizio in some surgeries. And the ureterial anastomosis, I can say to you that for me was easier to do in intraoperative, intracorporeal, sorry. Yes. The problem is not doing the anastomosis for me. The problem, I think, is I don't remember who did that presentation. Is that when you do a cystectomy, robotic cystectomy, you must have like a dancing with the operative team, as you understand me, as you can understand me. So everyone must understand what is the next step, what you have to do in the next step. Well, that's for me is the biggest problem, to have all the operative team connected to the like this dancing. And when you finish to remove the bladder, and then this is one question I would like to ask you, if you change the position of the patient. Another question is if the assistants stay in the left, like we have learned in Miami, and Dr. Fabrizio started with this way. And some steps, everyone must stay connected. For me, it's the most difficult thing. I'm a little bit concerned about implantation, seeding. But as you told you, it just moves the way it's seeding. we have to be aware in the open surgeon and also in the laparoscopic robotic approach. And I would like to ask you, how do you manage this? For me, the most important part is in the apse, when you cut the urethra, is the moment that you can see the cells to the peritoneum, and how do you deal with this? And another question is, if you, in your experience, depends on the sex. For example, male, you do nail bladder, and female, maybe it's not a good option for you. Well, some comments I did and some questions.
Nice. So you, by the way, your question about the position of the patient, we don't change the position. We have seen maybe 1 or 2 cases while performing a neobladder that the bowel didn't arrive to the urethra. So in that case, you have maybe to not have too much Trendelenburg, so you can change a little bit the position. But normally we didn't change the position of the patient. You have all the robot on the patient, so you don't have to change the position. That's the first question. The second one, the assistant is usually, we try, our assistant is on the right of the patient, okay? But you could also perform it from the left of the patient. I think it depends on where, how you are accustomed to do it. As you said, you have to function as a team during all the surgery. This is a very, very large surgery with a lot of steps. Everyone has to participate in the surgery, the assistant, the console surgeon, and all the team, I mean. So what we try to do in our hospital, we are 3 surgeons that are involved in radical cystectomy. We are only focused in urothelial carcinoma treatment. We are 3. So I don't perform kidney surgery, for example. I just focus in that in urothelial carcinomas. So I think that it's the best way to have better oncological and better functional outcomes. So we try always to be the 3 of us inside the operating room in all the cystectomies, so we can change from one to the other in the console. One perform the radical cystectomy, then the other perform the lymphadenectomy, then the other perform the urinary diversion. So we can change, and we are always the same team. So now when we are performing the intracorporeal diversion, we at first it took a little bit or much time than now, but now we try to do it as fast as we can, and we can do it in the morning, the cystectomy, without any problem. And the last question that you asked me about the risk of having tumor cells, no, spreading tumor cells with
and urinary diversion in male and female.
Okay, nice. So the risk of having tumor cells, spreading tumor cells inside an pneumoperitoneum environment, you try to remove the specimen en bloc and try not to enter into the urinary tract. So we just put a hemolock in both distal ureters, and we always try to dissect the urethra in order to have a thin urethra, to put a hemolock without any problem, in order to avoid a urine spillage inside the surgical site. So it's really rare to open the urinary tract during the cystectomy if you select the patient properly. I mean, if you have a PT4B tumor, I would say to go for an open approach, because it's really difficult to perform this procedure without touching the structures, and the risk of tumor seeding would be really, really high, okay? But you have to try to remove the specimen en bloc without entering the urinary tract, and in most cases, we didn't open the urinary tract as it could happen with the laparoscopic nephrectomy. And the last question is about the neobladder in male and female patients. at first we start performing neobladders in male patients, and now we also recommend to do it in female patients, and we have done several cases. And I mean, the main risk that you could find with a female patient is not about the risk of incontinence or urinary leakage. It's about the risk of retention. I mean, what we found in some women, in some female patients, is that she has to make autocatheterize the bladder for emptying the bladder. But we have good outcomes in female patients, and it's important to say that female patients are usually more worried about having a stoma in the abdomen. So you should go, or you should at least recommend or propose of undergoing a neobladder in female patients as well. I would say only one thing. We had a case in a female patient that developed, it was a neobladder, and developed fistula between the neobladder and the vagina. At first, we thought that it was like an urinary incontinence, but then we found a fistula, a big fistula. So we decided, and she also developed a ureteroenteric stricture on the right side of the neobladder. So it was a young woman. I mean, it should be about 60 years old. So we proposed to make a surgery to repair the fistula and the ureteroenteric stricture, and we decided to go for a robotic approach as well. It was a robotic radical cystectomy at first, and we decided to go for a robotic approach, but we explained the risk of having to reconvert to open surgery. And when we start, we found attachments, but with the robot, you can be confident about safety, the detachment of the bowels. So I don't have the video, but I will send it to you, or I will show it to you at least on Twitter. We have the video where I have to do it, but we have a video of the surgery, and we did it robotically. So we identify the fistula, then we cut the neobladder, and we redo anastomosis without problems. That the surgery went well, and we also reimplanted the ureteral stricture at the same procedure. So, I mean, when you have enough experience doing robot-assisted radical cystectomy, you can think about using the same platform for complications of the procedure.
Albert, about the technique, you are in the new bladder, okay? We're talking about to avoid the leakage of the urine, to put an envelope on the urethra, right? When you do the new bladder, what do? You put the Imoloc and then remove it, or you don't do that?
The Imoloc, we put it in the part that will be with the specimen. I mean, we put the Imoloc in order to avoid urine spillage in the surgical site, but not in the distal part of the urethra. I mean, so we try not to touch it. But the Imoloc, we put it in case of a male patient just after the prostate in the urethra. We put a Imoloc. So what it's important to say that it could happen that the Imoloc falls. So then what you have to do is try to remove the specimen as fast as you can and wash all the surgical site with a lot of water in order to avoid the spillage of tumor cells. Okay. Another thing, we don't know if we should open the abdomen in order to complete the surgery with an open approach in case that you have tumor spillage in the surgical site. But what you have to try is not to open, and if you open, wash and remove the specimen as fast as you can. But we put the Imoloc in the specimen, not in the urethra that will remain into the patient.
Okay. Thank you, Robert. We'd like to open to all people do some comments or question?
In the cases that you have performed in the in your hospital, which do you use like an endogia for the bowel anastomosis, or because we have changed a little bit? At first, we used endogia that was not an automatic. Now we use like a digital endogia. It's called Signia. That it's really easy to use it. So you, with the bottom, you can direct. You can change the direction of the endogia. So it's really easy to cut the bowel and to make the anastomosis. We have changed that that tool, and we have seen that it's really it's easier to use it to make the bowel anastomosis. It's called Signa. I don't know if it has the same word in Brazil. I guess that it's the same one, but it's like a digital GIA that is the assistant who used that GIA, that endogia. Is the assistant who use it, but it has like a button that you can move the top of the GIA to change the direction, and it's really it's easier, I think.
That's great, and probably you spend some time doing that.
Yes, we have opportunity to use one time the stapler of the Da Vinci. It's very good. It's better.
Helpful.
Fernando, I think that's maybe the residents are a little bit concerned about English. I have to say that Eugenia here can translate from Portuguese to Spanish or English. If someone wants to question something, any resident is here. Again, Albert, it's very good to have you here again, sharing experience. Let's wait if someone wants to say something. And it's very nice to have you here. I would like to say a question, another topic, just small words. How is the pandemic is there? How is being the coming to the new normal after this terrible period that we have passing?
Well, now we had like we return to normality at our hospital. We have a lot of population that have been already get the vaccine, so we hopefully. But what we are seeing now is that some people that has the vaccine get the virus as well. I don't know if in Brazil it's the same, but they don't go to the hospital. They stay at home, and they has like a more not as aggressive as it was with the vaccine. But we are a little bit worried about that people with the vaccine are being infected again. So we are a little bit worried, but we are function with normality at our hospitals. We are performing all the surgeries that are scheduled, and in the hospital, at least for now, everything is normal. We will see what happens. I don't know, how are you there?
Yes, the same. Since the pandemic has begun, we continue to operate. Of course, that the number of surgeries and attendance was decreased, but now we suffer a lot with material to sedatives and other stuff of surgery. But now we are returning. We have returned our robotic program, transplantation. We are also performing, as Fernando said, focal therapy to prostate cancer. We returned everything. And yes, tonight is the final of Copa America. Brazil, Argentina is the first.
I know.
It's the first time that we'll have public in the stadium, 10% of the stadium.
Nice, very nice.
Well, we are returning little.
Very nice.
I would like to pass the words to Fernando and Fabrizio to make his considerations. And again, Albert, it's a pleasure. It was an honor for you to have you here. Nice to see you again, even by the internet. I hope next year we can go to IAU, or maybe you come to Brazil to visit us. It will be a pleasure. Congratulations for your progress. I remember you as a resident. Now you are PhD. You have a lot of papers that you have published, and it encourages us in Brazil and we, Fernando, Fabrizio, and all our team to keep going in our urology program here in robotic program. And again, you are a friend of us. Okay, nice, very nice to have you here. I will pass to Fernando and Fabrizio.
Albert, thank you again. It was a really pleasure for us to have you here. And as Paulo said, we are hoping that pandemic is over. And as you said, today is happening the EAU Congress meeting, and it's online. And we hope next year we can be together and talk together and have a beer. So yeah, we miss that. We miss that. Those meetings are good, not only for the experience, but to be together and talk. And thank you again. We hope to keep this contact on other meetings. Our friend, you said your friend is Lucas. Would be a pleasure to meet him and to him to participate to our meeting. So have a great weekend. Enjoy the meeting, and thank you so much.
Thank you.
Albert, thank you very much. I'd like to visit you to learn with your experience. If I can, I would like it very much.
Of course. Thank you. You are all invited, of course. And I really want to thank all of you for inviting me. It's a great honor. And Paulo, it's really a great honor to contact you again after several years. So, and I want to thank you and congratulate all of you for this great initiative that you have doing these virtual events. I think that it's really good for residents, but not only for residents, for all of us. So I really congratulate you for this initiative. I think that if you continue doing this type of events, you will have more presence in worldwide. So it's really good, and it's an idea that I have taken note for my residents, and maybe I will come back to you to ask for a virtual meeting and to share your experience with us in a virtual meeting with us. So it has been really nice to be with all of you, and take care and see you soon. Hopefully not virtually. So we'll see what happens in the future.
Thank you.
Thank you, Albert. Thank you.
Thank you. Take care.
See you as soon as possible. Bye bye.
Bye bye. Adiós.
Obrigado a todos, gente. Bom final de semana a todos.
Adiós.
Adiós.
Muchas gracias.
Muchas gracias.